Good morning, everyone. Marina, I think we can hold on with the sharing the agenda until we all kind of we kick off.
Good morning, Judith.
Good morning, everyone. Thank you all for joining us.
Good morning.
Good morning. We're just going to let folks in. It's a big meeting today. It's jam-packed. So we will try to start as on time as possible. Good morning, everyone. Just trying to let folks in now. Good morning.
Good morning.
We're going to have a lot of guests today. If you're just now joining us, good morning. Thank you for joining us. We're still letting folks in. Good morning, everyone. Thank you for joining us. I have a few more folks in the waiting room. Just gonna try to admit everyone, and then we can start the meeting. Hope
Sounds good.
in about a minute. Just waiting for folks to move into the room. Okay. I think the waiting room is slowing down, but we'll continue to admit folks as we go. So Hope, I'll hand it over to you.
Sounds good. Well, we will call our August BHPAC council meeting to order. Welcome, everyone. Thank you for being here. We've got a jam-packed agenda today, so we're going to jump right into roll call because we want to get to our awesome presentation that we're looking forward to being a part of. So we'll jump right in. Aaron Black. I don't believe Aaron Black is here. Natalie Brown. Natalie Brown is not here. Savannah Brown. Savannah Brown is not here. Charles Davis. Charles Davis is not here. Carrie Eckert. Okay. Carrie Eckert is not here. Jacob Fry.
Morning, everybody.
Morning, Jacob. Thank you. Sean Gartrell.
Good morning, everybody. I'm here.
Good morning, Sean. Thank you. Kelly George.
I'm here.
Wonderful. Good morning. Thank you, Kelly. Laureen Gilroy. Looks like Laureen is not here. Marjorie Grimsley.
Here.
Thank you, Marjorie. Jenny Gwencheva.
Good morning. I'm here.
Good morning. Thank you, Jenny. Danielle House. Danielle is not here. Megan Lovelace.
Present.
Thank you. Dr. Asia Lyons. It appears Dr. Lyons is not here. Sharon Mock.
Good morning.
Good morning, Sharon. Thank you. Michael Miller. Michael Miller is not here. Dennis Streeter.
Present.
Thank you, Dennis. Angie Wold. Angie is not here. And Annette Zacharias.
Present.
Wonderful, thank you. I'll turn it over to our wonderful members of our state agencies. We'll start with the BHA.
Good morning, everyone. Megan Shelton here. I was director of strategy planning and engagement, and I'm transitioning. Wanted to tell you all real quick, I'm transitioning into a new, very exciting role. BHA is shifting a little bit the way that we do engagement, and it will be throughout divisions. But I have the honor of taking over as the advisor for Colorado for All, which is an initiative under Governor Polis, which really focuses on inclusivity and ensuring that BHA is meeting the needs of all people of Colorado. So very similar to the priorities of our engagement team, but being able to do it in a broader way that focuses both internally and externally at BHA. And I will join you all on camera momentarily, just having a little bit of a Wi-Fi issue this morning.
Hi, everybody. Aaliyah Andrews. I'm your recovery TA here. I'm the recovery services manager, and my pronouns are she, her.
I'll go next. Good morning, everyone. My name is Marina Borisov. I'm a strategic project manager, and my pronouns are she, her, hers. I will kick it off to Gordon.
Hello, everyone. I am Gordon Coombs. I am the 988 director. I use he, him pronouns, and let's see who hasn't. I'll turn over to Mark.
And good morning, everyone. Thanks, Gordon. I'm Mark Conajani. I use he, him pronouns. I'm the division director for the Adult Behavioral Health Continuum. And how about I'll hand it over to Mary Kay Mincer.
Good morning, everybody. My name is Mary Kay Mincer. I am the division director for children, youth, and families. I use she, her pronouns, and I'll hand it over to Alyssa Hetchel.
Good morning, everyone. My name is Alyssa Hetchel, and I am the division director over our BOSSOs, our new model of administering services here in Colorado. And I use she, her pronouns. And I'm not sure who else on our team. Judith, have you gone?
I have not gone yet. Thank you, Alyssa. Hi, everyone. Thank you, guests, for joining us today. My name is Judith Tiaku. I am the community engagement. Now my position is as administrator, and I help this council. I will hand it over to Sarah. Sarah is going to help us. Sarah and Marina are here today to help us with the meeting. But Sarah, do you want to introduce yourself?
Sure. Good morning. This is Sarah Lucas. I'm an executive assistant with BHA. Thank you.
I can go next. I'm Brianna Abb. I'm a budget analyst on the fiscal team. I work with Kasha and Monique, and I assist with the block grant reporting.
Hi, I'll go next. I am Monique Maurice. I'm the CFO here at BHA, and I'm not sure if Kasha's on the call. I know she was having some issues.
I don't think she's on yet. She just messaged me.
Oh, okay. Is that everyone from BHA? I think it is. I'll pop it over to Sharon from CDPHE.
Hi, I'm Sharon Liu. I'm the director for the community prevention and oh my gosh, early intervention. Sorry, it's early in the morning over here at CDPHE. And I have no idea who I can call on.
I think we can call on Andrea. Hasn't introduced herself.
Andrea Person. My name is Andrea Person. I am with Division of Vocational Rehabilitation. I'm a rehabilitation counselor, mentor, trainer, and program mental health supported employment program manager for Larimer County.
I can go next. I'm Phyllis Reed. I'm Director of Health Education Services Office at the Colorado Department of Education. And our office supports many grants, primarily right now, mental and behavioral health supports out in the field to schools. And I need to give an update that I haven't been able to do this week, but I will be retiring August 29th. And this year, in a few weeks. So I will be passing the baton to another fellow director in our unit, Sarah Blumenthal, and hope whoever I need to get this information, updated information to, and do an introduction, I'll be glad to do that, and I'll take care of that today. Thank you.
Thank you, Phyllis. Congratulations.
I'll go next. This is Chris Labanoff. I'm the Deputy Director for the Division of Criminal Justice, and I apologize for being off camera. I am double booked, so I'm on my phone, and I will be in and out of the meeting today, but I will do my best to attend to as much as I can. So thank you very much.
Anyone else that hasn't gone to introduce themselves?
I think Anne hasn't gone yet.
Yep, I was just unmuting. Hi, good morning. My name is Ann Denton. I'm your SAMHSA TA provider for Planning Council operations.
Awesome, Anne. Always happy that you're here. Is that everyone? Okay. All right. We're going to move to approve our July 3rd meeting minutes. Does anyone have any corrections or updates to share after reviewing the minutes? If not,
I don't have any suggestions. I just moved to accept the minutes.
Second.
Wonderful. Thank you. Our July 3rd meeting minutes have been approved. We've made a decision since we are really tight on time today. We are at 9:12 and we want to get to our presentations to start promptly at 9:15. I also, Anne, don't want to lose your having you be with us. I didn't know if there was an update from you from SAMHSA that you'd like to share before we.
Well, I have an update. I sent it to you and to Judith, but so the update is in the continuing resolution budget for next year that there had been a plan in the president's budget to consolidate 3 of the block grants and reduce the overall amount. And the mental health block grant and the substance use block grant were in those, and opioid. But that is not happening. So the good news is the continuing resolution authorizes the block grant at level funding for another year. And we're hearing there'll be no application next year. So the work that you're doing this year to put in an application will take you through. Yes, very happy. The other thing that it's kind of a mixed blessing, but that SAMHSA is very much at this point opposed to harm reduction activities. But they issued a statement this week that says that opioid, the naloxone, the life-saving drugs that you can give to somebody with an overdose, that those are exempted from harm reduction activities. So those activities can continue. So that's good for opioid treatment programs and homelessness programs in general. And that's my update. Thank you, Hope.
This is amazing. Anne, thank you so much. Wonderful news. Very welcomed. And we so appreciate you and your support. We are right about to jump into, on time, our SAMHSA combined fiscal year 26-27 block grant application presentation. We're so grateful for everyone that's here to provide this information for us. We're going to ask that after you hold your questions, and after each presenter, there'll be some time to ask a little Q&A. So as things come up during the presentation or after reading the slides, what you may already want to ask, if you wouldn't mind, just write those down, keep those close, and we will hold on to those until after each presenter. We'll have a little time for Q&A. So here we go. We're going to kick this off. A very important August meeting we have here, and I'll turn it over to you, Judith, to take it away.
Thank you, Hope. I will just do a few intro slides before I hand it over to our guest today to present the goals and expenditure. Next slide, please. So today's agenda is just really, and we're going to go through just briefly, reintroduce the purpose and role of this council. I know you're all already aware of it. It's a good way to just refresh our memories about what really our role is and the importance of today's meeting. And then we'll kick it off to the BHA leadership to present on the BHA goals and proposed expenditure for the block grant. Next slide, please. So I know you've all probably seen these slides before. I'm just going to run through them really quickly and briefly, just to say that the purpose of this BHPAC is really to support BHA's effort when it comes to mental health services in Colorado. Next slide, please. And so here are some of the primary responsibilities of BHPAC, the council and the council members, is to really support the block grant application, help with report, and then also provide recommendations to BHA when it comes to mental health work in Colorado. Next slide, please. Here is a table just outlining the next couple of years and the year before, some of the deliverables that we've worked on. And so this year is a combined application year, meaning that is going to be a full application year, hence the big meeting today and with lots of input and priorities to cover. But this year, BHA is going to submit the full application. And the reason this group is here is because BHPAC is required to have an input in the submission of the application. And so the application is due on September 1st. And then last year, there was a mini application, which will also be due next year. So the even years and then odd years would be the full application. So here are a few other reports and then the due dates for those. Thank you. Next slide, please. And so here is a slide just putting side to side, just a full application, what should be in the full application and in the mini application. You'd see that in the full application. For both applications, BHPAC needs to review and then respond, but especially for the full application, that really includes both planned expenditure for 2 years and then also performance indicators. And we will also have public comment on the full application after this process, which is also kind of a separate process before the application is submitted. Thank you. Next slide, please. And here are some of the primary responsibilities of BPAC, which I've mentioned some of that a little while ago, but it's really just ensuring that you review the applications, make recommendations, and then put together a letter of recommendation that the chair will submit that will go along with the application that BHA is going to submit to SAMHSA. So this year we're on a super tight timeline. If you would recall, this application was not released at the time that we usually anticipate that it'll be released. So it was released a little bit later. And so we are really kind of in a very truncated timeline. What we're doing is after this presentation, the council will have some time to add more recommendations. I know you've all already started working on providing recommendations to the block grant subcommittee, and so you have additional time to add a few more recommendations after you've heard everything and the priorities and proposals today. And then the block grant subcommittee meets next week Thursday, and so they'll be able to review some of the additional recommendations that council has provided, and we'll keep working on really fine-tuning those recommendations. And then also, of course, knowing that this is it's a kind of a year-round role, really, and responsibilities. And so after this is submitted, here are some of the ongoing work that council members, you've all really dedicated your time to doing on this council. Thank you. Next slide. Next slide, please. Thank you. I am going to hand it over to Mark. Mark will kick us off with the priority areas and then present on the priority areas that Mark's division works on. So I'll hand it over to you, Mark.
Thanks, Judith. And again, Colorado is a state that submits a joint application or a combined application, I think is the right term. Because again, in statute, there's a mental health block grant and there's a substance use prevention, treatment, and recovery block grant. We're trying to have more integrated care, but each of those block grants have specific priority areas that we are required to put some goals in. So you can see in parentheses for each of these goals, we kind of list the team that each of these goals will be kind of led by. So I'll just read through, and we're going to, first one is around increasing community services for people with serious mental illnesses. That'll be in my division. Next, provide behavioral health treatment and wraparound support for children and youth with serious emotional disturbances and individuals with early serious mental illnesses. The CYF division will manage that one. Provide effective treatment for pregnant and parenting women with substance use disorders. Again, the CYF team will handle that one. Provide effective treatment for people who inject drugs. I'll manage that one, talk about that. Identification and referral to appropriate care for those with tuberculosis and other communicable diseases. I'll talk about how we will achieve that goal. Prevent and reduce substance use and improve community services and wellness in youth, young adults, and their families. Sharon Liu, CDPHE, will handle that one. And then expand recovery support services for people with behavioral health needs. That one will be in my division. And then strengthen the crisis continuum of care. And Gordon will speak on that one from the 988 side of the house. So let's go ahead to the next slide, and I'm going to jump in greater detail about the priority areas 1, 4, 5, and 7. So priority area 1, again, adults with SMI. And just to give some background, I think in the past we've simply used that favorite 4-letter word here at the BHA called CCAR, along with encounter data to just identify, hey, are people that are the public behavioral health system, the safety net system are serving with SMI, are they getting services? And so we looked at how many CCARs we had, what percentage of people were getting ongoing services. The landscape in Colorado is evolving for sure. We are under a consent decree. We have too many people with serious mental illnesses that are unfortunately going through the criminal justice system instead of being managed by the safety net system. We want to do some things to alter that and to provide more effective community-based care wherever we can. And so a couple strategy areas, there's been recent legislation to allow someone that's been arrested, that's been found incompetent to proceed, where they might say, you know what, this person isn't, restoring them to competency so they could stand trial for a misdemeanor isn't serving justice and isn't serving this person very well. Wouldn't it be better if we're able to move them to the civil commitment process, if it's appropriate, if they meet criteria, and have them managed by the safety net system instead of the criminal justice system? So increasing community capacity for people with SMI. We want to leverage our outreach and care coordination and care navigation through our BOSSOs. Some specific strategies, as I just mentioned, we want to support that ITP to short-term CERT. That's what those letters stand for people with misdemeanors. Also, with the creation of the BOSSOs, we have a new system where we have kind of three-tiered approach to care coordination. Tier one is basic care navigation, helping people that are just trying to find care, connect to care, right? And so that's kind of the simplest level. Tier two and tier three are for people with more complex needs, and are often going to include adults with SMI. And so we have a way with our BOSSOs in the contracts so that we can identify how many unique people they're serving with each of these levels, tier two and tier three of care coordination. And I just want to, what I don't include in the slide are some of the goals. And then the last kind of strategy is increasing statewide utilization of outpatient certifications to support people with serious mental illnesses. Again, I think, what we can see in our system is too often people will just cycle either in and out of jail or in and out of hospitalization, which can be stabilizing, can be traumatizing, can be very challenging. And what we really want to be able to support is community-based ongoing care and support. And so being able to have our safety net providers be able to maintain an outpatient certification so that we can help people stay in community, stay healthy, stay on the recovery path is one of the areas we're looking at. To give you a sense, the law was passed for that first strategy, ITP to short-term CERT, and most of the referrals were people, unfortunately, with violent felony offenses. And surprise, surprise, a lot of private psychiatric hospitals were uncomfortable accepting that referral. So our baseline is really zero. The good news is we're starting to work with our state hospitals and more effectively with the courts to identify what the legislation really focused on, which is people with misdemeanor crimes, and see if we can manage it. And we've had some receptive hospitals already. So we're having some success here. So our goal on that particular one is year one, we want to be able to successfully use that process of diverting people out of that ITP system and into short-term CERT. We want to have that for 15 people. And then for year two, we want to be able to serve 20 people. Now, my hope is we actually are even more successful than that. But since our baseline is zero, we want to set a modest goal and make sure we start working effectively with the courts and private hospitals to be able to achieve this. The second one, tier two and tier three, means care coordination or care management. Again, BOSSOs are brand new, so our baseline for BOSSOs doing it is zero. So our goal in year one is we have a target of, let me see if I got this right. So tier two, we want to serve 200 people. And in tier three, which is the much more intensive case management work, we want to be able to serve 50 people with this level through our BOSSOs, this level of care coordination. And then a 10% increase in year two, so up to 220, and then up to 55 for people getting tier three care coordination. And then increasing the amount of people that are maintained on an outpatient certification. We do have a baseline there. We had 426 people on an outpatient CERT that ended in FY25. And so our goal for year one and year two is to increase this by 10% each year. So that's what we're trying to do, to be really targeted with some strategies to do better community-based support to help people successfully be in the community, avoid the criminal justice system, and hopefully avoid long-term hospitalization too. So I'll move to the next goal. I will have time for questions when I'm done all of my sections, so go ahead and keep track of those. And Judith will also be telling me when I'm falling behind. I'll see if she already had. All right, priority area 4, persons who inject drugs. This is a more of a mature measure that we've had in the past. We're able to use our data systems to identify people who are admitted, who identify their route of administration for substances, either for their primary, secondary, or tertiary drug abuse as being by injection. And that helps us identify, okay, here's the population we want to track. We want to see, are those people admitted into treatment within 7 days? Prioritize timely access to outpatient treatment, and that's what we specifically mean there. And then the next part is reduction in substance use for those who access treatment. For awareness, the block grant requires that anyone with who uses people who inject drugs seeking care, they're required to be admitted within 14 days, or again, interim services being offered. We set this goal at 7. We think that that's much more reasonable and attainable. And in fact, our history shows that our baseline has been 93% of people are admitted within 7 days of seeking care. We know, for example, when we're dealing with people that are seeking care through opioid treatment programs, and we know not all the people that go to those treatment programs inject drugs, but nonetheless, most of those OTPs are able to have same-day access to care, and that's been a huge improvement in our system over the last 5 years. So 93%, and our goal really here is to maintain this level of care. We're not looking to really push it too hard, especially in, I'll just say, a fragile financial landscape. We don't want to set goals that are going to be very aggressive when there's the potential of either state or federal budget cuts, and hopeful comments notwithstanding. So I appreciate those hopeful comments. I've seen those as well in terms of keeping our block grants and our SOR grant whole, but we don't want to push this goal too much. Same thing for the reduction in use. The indicator there, we've had 83% of people who seek services, who inject drugs, who show a reduction in their substance use from admission to discharge. So we're having some good success in terms of being able to make services accessible and services effective. So we want to maintain that level. So we want to make sure that the quality of care stays strong. All right, let's go to the next goal. And so this one is individuals with tuberculosis. Now, Colorado is not a high-risk state, although we have seen a little bit of a jump in this area. But one of the things SAMHSA knows, and we understand, is that people with tuberculosis, if they use substances, particularly if they're using alcohol, the health outcomes are way worse, right? So it's long been understood that we need to identify and use our substance use system to identify people who are at risk. And so we've long-standing had part of our rules for behavioral health entities, and that they do a screening to identify people, not just for tuberculosis risk, but also for other infectious diseases. So every time an agency gets a licensing renewal, a chart audit is done by our Quality Assurance and Standards division, by our licensing staff that go out there. And those are all captured on an Excel spreadsheets. So our amazing technology and data team is doing an analysis of all those chart audits to clarify exactly what was the baseline on that item, to see where we're at. And again, to make sure that we're maintaining fidelity, that our providers are following that rule and making sure that they're screening for people, and that people that have identified risk they're referred for the right follow-up care so that we can get them the healthcare intervention that they need. Pretty clear, and I will move on. So we may, once we have some hard data on what that baseline looks like around compliance on this rule, it could inform whether we need to kind of tighten this up a little bit with any number goals. But right now, adherence to this rule and us having this rule is one of the ways we meet this block grant expectation. All right, let's go to the next goal. And this one is state priority for recovery support services. Now, we've really been trying to grow the recovery support realm within our work. And that really involves a lot of peer support through recovery community organizations, building the workforce, do put a lot of efforts into trying to provide training to help more peers get certified as peers, to look for sustainable funding. And we've also in the past put some focus on building recovery housing capacity. With some of the changes in Medicaid that are coming here, as well as increased pressure on funding, we really want to kind of push to further support the advancement of this part of our field because we see it so important. We do have the ability for recovery community organizations to get licensed in Colorado as recovery support service organizations. The benefit of getting that license with BHA is that it opens the door for Medicaid billing for Medicaid members. So that some of these organizations are less reliant solely on grant funding, which we know is vulnerable, right? ARPA grants have pretty much dried up. And so we really want to make sure there's more opportunities. So we have two goals: increase the number of RSSOs and the number of RSSOs that are able to bill Medicaid, and then increase the number of certified peers. So the increase in the number of certified peers, that's a goal we've had the last couple of years, and we've met and exceeded our goals there, which has informed our baseline. So just to give you some of the data, we have 11 RSSOs licensed in Colorado. That is it. That's all. We know there's many recovery community organizations that are out there, many that get funding through our BOSOs, as a matter of fact, or directly from BHA. We want to increase that from just 25% from 11 to 14. We want to get more. Additionally, of those 11 that are currently licensed RSSOs, only 3 of them are billing Medicaid at this point. So we've worked with our Medicaid authority to really look at these organizations, see if they're billing Medicaid under their RSSO license. And so we want to improve that. Again, set a modest goal in year 1 to go from 3 to 5. It's a 66% increase, but 3 to 5 seems incredibly reasonable. I'll be honest with you, for all of these, I hope we blow these goals out of the water because this isn't good enough. But I also wanted to kind of make sure that they're achievable at this point. Year 2, we want to go from 14 to 18 recovery support service organizations that are licensed, and go from 5 to 8, the number of RSSOs that are able to bill Medicaid. The number of certified peer mentors at the end of state fiscal year 24. Let me see. So we had 408 at the end of by June 30th of 2024, and we had 645 certified peers at the end of fiscal year 25. June 30th just ended. That is a 50+% increase. That's amazing because we put a lot of effort into this. We don't want to let up. Although we did set a more modest goal of just 10%. And again, those were our goals in the past and we blew away those goals. I hope we blow away those goals again. So we want to increase the number of certified peer mentors by 10% for state fiscal year 2026. So we want to get up to 710 and then another 10% increase for state fiscal year 2027. So setting a goal of 781 is what we want to be able to have to build that certified workforce. Why is this important? Again, BHA rules, Medicaid rules for reimbursement. They want to make sure that the people that employ peers are either behavioral health entities, safety net providers, or RSSOs, right? So they're looking to BHA's kind of qualification, and those qualifications are requiring that you use certified peers. That's going to be an increasing issue as well. The peer that's delivering the service for it to be Medicaid reimbursable and likely BHA reimbursable, we're going to be moving towards that certification. So we need to put the kind of pressure on and support on to help this part of our industry get to a point where they have that ability. It's high quality care. There's sustainable funding, and yes, part of that will be also making sure reimbursement rates are a part of that too. But right now, these are the areas that we're putting some energy into. Okay, I'm gonna open it up for Judith told me a minute ago or 2 minutes ago that I had 1 minute left, so I'm over. But some questions. I can take 2 questions, and there'll be time at the end for some additional questions before I hand it over to Mary Kay. Tasha, I see a question in the chat. Do you want to elaborate? So I make sure I understand, and then I see some hands up as well.
I'm just curious to see the numbers between different stuff that's licensed with the BHA and everything else like that. Peer support is like out the water. Mental health should be a priority because that's preventative when it comes to substance use disorder. So I'm just wondering why there's not a big emphasis on the mental health numbers for the services, especially with our children and youth and adults with disabilities and stuff like that. There's more emphasis on the addictions.
Okay, particularly around the recovery sports stuff. Is that what you're talking about this last call? I think that's a great point. We do dedicate a portion of both our mental health and substance use block grant in the recovery realm. And even though it's our substance use prevention treatment recovery block grant that has prioritized that we need to have a goal in this area, I want to point out that the way we wrote that state priority area, expand recovery support services for people with behavioral health needs. We don't say substance use needs. We are being more inclusive in that language because that RSSO can be for a mental health focused RCO, a substance use focused RCO. Those services are reimbursable under Medicaid when you get that. So we wanted to be very open in that. Same thing with the peer mentor credential that is offered through IC and RC. I know there's other options. That's the one that we've kind of promoted because it is more available if someone's specializing as a family navigator or a mental health peer mentor or a recovery coach. Anybody that kind of works in each of those can get training that will allow them to get that credential that COPA offers. So we hear that, and we want to support peer support and recovery support services for people across the behavioral health spectrum. Marjorie? I could be wrong if someone else had their hand up first, but go ahead, Marjorie.
I just was wondering, when you're talking about timely access to outpatient treatment as well as those, I'm assuming accessing treatment in a more of a facility, does that also include that step down care that when someone leaves a facility or wherever they're receiving their treatment, that transition care, step down care is included in that process to ensure that when they leave, they are going to also continue to be connected with the system. So you've got your prioritized timely access to outpatient treatment, but I just want to make sure that it includes that prevention on the front end, but as well as that step down when people move from one level to another after receiving their care. I hope that made some kind of sense.
I think so, and I think the place that you're looking at is the priority area for people who use who inject drugs. And again, measuring timely access for outpatients was intention. And again, the people getting access to outpatient care could be the first treatment they're getting or treatment after stepping down from a higher level of care. So it's going to include anyone that's moving up or down the continuum, but we are looking at the outpatient access within 7 days. Inpatient access within 7 days is a harder thing to guarantee because bed limitations are bigger. On the persons with SMI goal, remember we did have that focus on that increased focus on outpatient certifications, and that's really people that might be leaving psychiatric hospital levels of care, who continue to need that ongoing support in the community, that we want to make sure there's that transition and step down to to an outpatient certification from that residential, so that the safety net system is able to welcome them. Outside of our block grant goals, we have a lot of those goals that we are working on with our bosses in terms of making sure that we don't lose people from high levels of care as they step down to lower levels of care, because we're going to spend that money as a system, whether it's Medicaid or ours or others or families' money for that intensive care. We know that if they don't get continuity of care in the community, they're going to struggle.
I guess that captures it, and it's just that making sure that transition component is the rule, not the exception, and that often is the case. So thank you.
Gotcha. And I gobbled up too much time, so I'm going to hand it right over to Mary Kay that can talk about the goals for the CYF division.
Thank you, Mark. Thank you all for your questions. These are great questions, and I know they're being tracked, so we will make sure to get you answers. I will be reviewing priority areas 2 and 3 for children, youth, and families. Next slide, please. Okay, so priority area 2 for these block grants is children with serious emotional disturbance and individuals with early serious mental illness. Our overarching goal is to provide behavioral health treatment and wraparound support. So Marjorie, that kind of gets at your question around the step down piece, right? For children and youth with serious emotional disturbance or SED, and then individuals with early serious mental illness or ESMI. And so our proposed strategies to reach that goal, we have 5. And so on this slide, it's the first 2. Provide core mental health services to children and adolescents with SED and ESMI and their families. And this is a longstanding historic goal that has been part of our block grant applications for years and years and years. And then the next 4 are actually new goals that we have added based on some phenomenal work that's been done by our project managers. And so this first one, or the second one on this slide, but the first new one, is utilize the statewide standardized assessment tool to identify children and youth who would benefit from intensive services and ensure linkage to the appropriate level of care and or supports. Next slide, please. And then additional strategies. These are specific to the ESMI population, and these were informed by TA work that we did with SAMHSA. So they have a technical assistance for early serious mental illness that our project manager participated in for the last year and really stood up some great data to support that population specifically and to make sure that we're tracking it in a robust way. And so the first goal for the ESMI population is to reduce the duration of undiagnosed psychosis for individuals with first episode psychosis through timely access to ESMI services. The second is to reduce the number of preventable hospitalizations for individuals with ESMI. So again, making sure that we're taking care of them in the community, making sure that community supports are more robust so they don't need to be hospitalized. And then last, reduce the number of suicide attempts for individuals with ESMI. I have indicators. I know that there were questions about that data. I think that we're going to find a way to get that to you. So we will share that with you, and I'm just not going to review them here in the interest of time. If I could go to the next priority area, please. So priority area 3 is pregnant and parenting women with substance use disorders. Our overall goal with this grant is to provide effective treatment for pregnant and parenting women with substance use disorders. Again, this first one is a historical one that we've been tracking on for years and years and years, and we've got great data around it. And so we want to make sure to continue it. Actually, and so the first strategy for substance use treatment is to provide core substance use disorder treatment to pregnant and parenting women diagnosed with or in recovery from substance use disorders. And then the second one is more around really making sure that as a state, we are having providers that are providing gender responsive care. And so to monitor and update the gender responsive treatment rules for specialized training and or best practices for providers practicing within gender specific SUD programs. The next slide, please. This is also a new strategy that we're adding. We really wanted to focus on upstream prevention and not only in treatment and making sure that pregnant and parenting women are getting the support that they need in treatment when there's a substance use disorder, but also actually identifying if depression or substance use disorder is at play when someone is pregnant or when they're a parenting individual. And so again, the overall goal for this priority area, it aligns with the previous slide to provide effective treatment for parenting and pregnant women with substance use disorders. But then the strategy is a prevention strategy, and that is for us to recruit hospitals, outpatient clinics, and community-based organizations to participate in perinatal behavioral health screening, practice transformation, and quality improvement programs. What that basically means is that we'll be working with those particular sites to ensure that both depression and substance use screens are being administered, and that when there is a positive screen, that follow-up and support happens. And then the next is to engage in perinatal healthcare delivery system. So both the inpatient and outpatient settings to adopt this universal perinatal behavioral health screening. And then finally to support the healthcare delivery system in developing meaningful workflows when there is a positive screen. So I just want to do a time check. I'm seeing that there is some questions, but I also want to make sure that everybody else can get through their slides. Judith, do you have a recommendation?
2 minutes, please.
Okay. I noticed that Megan asked a question about sorry, you can read the slides. We can read the slides. Can you say more about the work, please?
Megan, do you want to make a comment?
Just a request to kind of expound on the slides instead of just reading them to us, sort of, you know, how Mark gave us a little more information in the space than what was on the slide. If you could please also do that so that we can learn more about this great work as you're presenting. Thank you.
Is there a particular work that I talked about that you'd like me to focus on?
No, just in general.
Okay. I will note that for the future. I appreciate that. And I'm just, I'm gonna, I think that does anyone have any particular questions about the strategies that I presented? Okay, I'll pass it on to Sharon. Thank you.
Hi, everyone. I'm Sharon, and I am the director for the Community Prevention and Early Intervention. And we took over, well, we get the 20% set aside. And hold on, next slide, please. So to back ourselves up, we actually we're part of the SUPTERS block grant, and we have a 20% set aside that has to be used specifically for primary prevention. And so right now, what that really means is that we work with the general public and not with anyone that has been diagnosed with an SUD. So I just want to make that clear. We're really working upstream. Next slide, please. And so what do we mean by upstream? As you can all know, you can read that definition, but we're really trying to get to people before, like I said, they get diagnosed. And then what we also try to do is make sure we have a comprehensive primary prevention system. So our approach in Colorado, like I said, we target the general audience, but then we do also target, for instance, maybe some youth that have high-risk needs or several ACEs, adverse childhood experiences as well. But most of the time we are working with those in the general realm, general population, those who have not who haven't even gotten in trouble or anything for substance use, especially around youth, young adults, and families. And the reason why we focus on that is because we have science to back us up that that is the age group that you can make the most impact when working with that group. So we are based around prevention science, and what this means is this can lead to cost savings if you invest in upstream prevention strategies so that you can avoid some of these downstream costs. So then in terms of comprehensive primary prevention, what we mean by that is not one strategy can be used to say, hey, that's prevention. You might have seen a lot of prevention strategies, for example, like information dissemination, like a campaign or something. But if you don't have anything behind that that's going on in the community, that message is not going to really change people's behavior. It might give them knowledge, but are they really gonna change somebody's behavior? So what we have in place is you have to do more than one strategy. You have to have not only maybe a campaign, but you have to have some education along with that. You have to have some policies that build around that, and also kind of a system in place to address that. So also in Colorado, I wanted to let you know that we have an infrastructure in place that addresses substance use primary prevention, and that is we have a state epi outcomes work group that looks at trends of substance use data that could be used by not only prevention, but treatment and recovery services. We have a learning management system that we provide. We also have training and evaluation and coaching for all of our providers. And then we use the Healthy Kids Colorado Youth Survey to see how we can make an impact. So then, next slide, please. So then our priority for the 20% set aside is we're trying to reduce substance use, improve community systems. And so how we're going to go about doing this is we have been working on a new request for applications that will go out sometime this fall. I'm just going to talk a little bit about it because this is going to set us up for the next round of what we're going to be doing for our 20%. So right now, since we're at the Colorado Department of Public Health under the Prevention Services Division, we also have another group that is funded by state marijuana tax funds. So our two units are going to be working together because we don't have a lot of prevention funding throughout the state. So we know that we have to make the most out of this funding. And what we're going to do is really work with communities to come up with a collective impact system so that they can really address the primary prevention substance use efforts that also align with community needs. We have done a needs assessment and we have done a strategic plan. So we have our next 5-year goals, and we've been using that data to help us kind of prepare for this next round. So we're calling this EPIC, Elevating Prevention in Colorado. And what it's going to do is we're going to combine funding at the state level, our level, to meet the community needs, so federal and state funds. And we're going to fund these communities so that they can implement 3 prevention strategies. So we're thinking community-based processes, which may be like a coalition, an education, and an environmental. And environmental means some type of policies that can be done in a community. For instance, maybe some of you have heard about social host ordinance, which is something where if parents get caught with serving alcohol to their youth, there may be additional fines or charges against them. So that's just something, you know, in regards to policies, school policies around drinking, that can also be a part of this. And then not only will they be required to implement these 3 strategies, but come up with outcomes. And really what it is about supporting the community needs and getting to some of the root causes that are causing some of the substance use in the communities. We're going to be focusing on, as a state, we're going to be focusing on substance use, especially around underage drinking, alcohol, cannabis, and prescription drugs, especially around public middle school youth, because we have noticed that the data has gone up in some of these areas for middle school youth. And just to let you know, EPIC is based around all these theories such as socio-ecological model, the strategic prevention framework, ACEs, and then one of our indicators, as I was talking through, is we're going to be either maintaining or decreasing alcohol, marijuana, and prescription drug use. We're going to be using this year to collect baseline data as HKCS, Healthy Kids Colorado Youth Survey, is going to be implemented this fall. It's administered every other odd year for that, so that's why we have to kind of wait for our baseline data. And then I should also say that usually Bonnie is our representative here, but Bonnie is actually presenting at another conference. So I am giving this whole overview because I get to be the lucky one to work on the block grant application. So wanted to know if you have any questions. Sorry that was not as smooth as I would have liked it. I know we're kind of down to time and everyone probably wants to get a break. So, but if you have any questions, please let me know. So somebody asked, youth coming out of detention centers. No, that's not our focus when it comes to primary prevention, because they are, they may have already been diagnosed with something. We are mostly working upstream, so that's more of the general population. But I know that, you know, prevention has many different levels. So I believe there's, like I said, we're primary, so we really work with those that have not been diagnosed or have showed a problem quite yet. And then, will these dollars be available to youth with mental health needs? So as a part of substance use prevention, mental health goes hand in hand with that. So our programs are mostly building that resiliency skills in youth to figure out how can we cope with things that are coming up. How do we, you know, do other things that are healthy instead of turning to substances? And, you know, there's a big social norm around that. Like, as you all know, when we celebrate, we tend to use substances. When we're feeling bad, we tend to use substances. So our job is very hard, in which we're trying to break some of those norms and say, hey, you don't have to use those substances to make yourself feel better. Let's figure out other ways in the community and environment to help you make those healthy choices. So that's what we're really trying to do. And I think if there's any other questions, I think you can put it in the chat and we have time afterwards to kind of address those. Thank you. Judith?
I think Hope is gonna send us to break.
Sure. All right. Thank you. We're going to just take a quick 5-minute break to get up, do what you need to do, so we can come back with some fresh minds and ears to continue these awesome presentations. So it's 10:03 now. We'll see you back here at 10:00. It's 10:04. So we'll see you back here at 10:09. Thanks, everybody. All right, that's quick. 5
All right.
minutes. It is 10:09, everybody. Welcome back. I hope you had a chance to do whatever you needed to do. We are going to move over to continue our presentations. I will turn it over to Gordon to take it away.
Hello, everyone. Just a reminder, I'm Gordon Coombs, Director of 988 Colorado. Next slide, please. Just to state the goal and objective, it really to strengthen the crisis continuum of care here in Colorado, leveraging 988 as a front door to access crisis services and increase coordination with public service answering points. Next slide, please. So strategies, the things that we're doing to accomplish this, really sustain and scale public service campaign with the intention of pushing out 988 as really that front door. So we've been really active and involved in a marketing campaign, outreach in the community, all of those types of things to get people to understand that 988 is out there and accessible to all people of Colorado. A big piece of that is the consolidation of the Colorado Crisis Line, or the Legacy Colorado Crisis Services Line, into 988 Colorado. That occurred on July 1st of 2025. That line is still active. That 10-digit number is still active and routed to our call center here in Colorado. So people can still call that legacy number, but we're really trying to push them to 988 Colorado and the 3-digit, much easier to remember number. Enhancing language access. We are primarily English and Spanish, but we do have, our contact center has over 150 language options available using Language Line, and also American Sign Language available options as well with our contact centers. The next big piece of that is really on the PSAP side of things. So public service answering points are those PSAPs. We're engaging with PSAPs to transfer more 911 behavioral health crisis calls to 988, expanding the number of PSAPs that are equipped to directly transfer those. We'll talk through some of that. And then improving technology and infrastructure when it comes to 988 and support. So how do we better respond to, with technology, people accessing support within Colorado. And then shared protocols to divert non-emergent calls to 988 from those 911 traditional 911 calls. Next slide, please. Just wanted to set some context as far as what our call volume here is in Colorado. Currently, we get over 90,000 calls to our 988 line. We get over 145,000 calls to our CCS line. So that line has been around and is more well known. So we're starting to see those numbers shift. More important as well is what you'll see is the in-state answer rate. So right now, 95% of our calls are answered in the state of Colorado with our Colorado call centers, and then our CCS line is about 96%. And then our other modalities, calls, chats, and text. One thing about the text on the CCS line, those are impacted by geo-routing. There is a new rule that went into place as of today, I believe, or yesterday, which applies geo-routing to text. So we're going to start to see those numbers tick up and make sure that those CCS line texts are geo-routed to our contact center in Colorado. Next slide, please. So our indicators for this priority area really are the calls routed to our 988 Colorado Contact Center, which is staffed by supported by Solari, our contracted provider. What we're looking at is the percentage of those calls. Our target goal is 90%, and as you saw in the last slide, we are actually operating above that. That number tends to fluctuate, and there are several factors that play into that when it comes to those numbers. And I'll talk through some of those challenges, but we're looking to continue to increase that. When we talk about those challenges, there's national level data that doesn't often align with state level data. So we're continuing to monitor that. The percentage of calls diverted to the contact center are a result of the national interactive voice response options. So calls that go to 988 first go to the national line. There's an IVR, that interactive voice response option, and then they get routed to Colorado if somebody doesn't pick one of those other options. So we're doing a lot of things to kind of address that IVR. We also know that there's a lot of dropped calls as a result of that IVR. So we're exploring legislation that allows us to increase the in-state answer rate even higher than that 90% and even the 95% that we're operating at currently. And ultimately, what we'd love to work towards is to live answer with the Colorado Mental Health Line here in the state. Like I said, the Lifeline Network Administrator, Vibrant, reports national level data. It's really hard for us to get specific Colorado data. There's a network agreement in place that limits what data we can actually get from our own vendors. So Solari and the Evaluation Center, which is out of the University of Colorado. So we're working on storing some of that stuff up and getting more access to some of the better data to really understand and adapt to what the ongoing needs of the people of Colorado are. Next slide, please. All right. So this is the next big one. Indicator 2 is the number of PSAPs participating in in-call transfers from 911 to 988. So the number of PSAPs participating in call transfers, right now we have agreements with about 12 of the PSAPs in the state of Colorado. We're looking to increase that by 10% this next year, and then by an additional 10% the following year. That's a really conservative estimate. We do think we can get a lot higher, acceptance and onboarding of that. Because what generally happens is as we bring on a PSAP, then nearby communities or nearby PSAPs tend to fall in line with them and also join as well. Right now, we have a staff member that is funded through our discretionary SAMHSA grant for 988 that is dedicated to this work. He's a retired law enforcement officer. So he is bringing together a deep understanding of the emergency services and 911 and can speak the language. I also am retired law enforcement, so I bring that as well. So really, a lot of this work is relational and getting out to the PSAPs and law enforcement, fire and first responders to really get them on board and build trust in diverting those calls. But it is working, and we're moving forward with that. Some of the challenges right now is there's informal or ad hoc transfer methods. So are there ways that we can use technology to better incorporate that transfer method from 911 to 988? There's right now a lack of any statewide infrastructure to track 911 to 988 calls. So we want to look at ways to put that in place and working with our 911 counterparts. As you can probably imagine, there's a lot of variability or regional variability to IT infrastructure when it comes to dispatches. There's no centralized dispatch in the communities throughout Colorado. So this is a lot of legwork to get out and work with law enforcement agencies, fire departments, emergency services to really get them on board and see the benefit, as we see, to get 988 response as opposed to law enforcement and emergency services response if it can be avoided. And then standardization of the definition of participation. So what this really means is a lot of it is informal. We want to have memorandums of understanding in place to really drive cooperation and put in place systems and processes to make those transfers, so that 988 is really the primary response method when it comes to behavioral health issues that we're seeing in community. So those are our priorities and our indicators. Again, trying to move fast because of time, but wanting to answer any questions that may be out there. And one of them in here is, will additional infrastructure require legislation to fund? So right now, for those of you who don't know, 988 is funded through the enterprise, Tabor Enterprise. We are funded through a fee that is attached to phone lines, and whether it's mobile or landline. There is a recent ruling that impacts our ability to collect on prepaid cellular. We're trying to work through that when it comes to legislation. But the current Tabor rules allow us to charge up to 30 cents per line per month on those fees. There may be a need as we look at legislation to adjust that funding cap. When it comes to the Tabor caps, that has to play into it as well. So that's a possibility when it comes to infrastructure change. We're also seeing an increase in call volume when it comes to consolidation and the ending of the number 3 option at the national IVR for LGBTQ plus population. So that's also feeding into some of the increased call volume that we're getting and our ability to respond to it, and increasing the existing fee at this time. Any other questions? All right.
This is Margie, and I just have a quick question. With the LGBTQ plus, the change in not having that separate line, are you educating your call takers so that they are able to meet the needs of those that are calling in for that unique and special support?
Yes, absolutely. Thank you for asking that. Yes, all of our contact center operators, our trained crisis specialists, are trained to work with all populations, including LGBTQ plus populations. What, the silver lining in that change is that now, instead of the number 3 option and being callers choosing that being forwarded to a national call center specific to that, those calls are now really routed to our Colorado contact centers, where callers can be not only supported through our contact centers and our inclusive conversations with them, but also can be connected to services local to Colorado and their communities. So we're responding to be in fact, even more responsive to the needs of that population, as well as all others.
I guess I just really think that needs to be, people need to be made aware of that, because I'm sure that there are I shouldn't say a lot, I'm sure there are people that don't call in because that no longer exist, without realizing that that extra effort is there and that they still can receive appropriate support. So that might be something educationally wise, and maybe all of us on this call can spread that word. Thank you.
Yes, please get the word out related to that. We did put out a press release related to that. Got a lot of media attention. I did a lot of interviews with local media about that, with the entire emphasis of we are open for business for all people of Colorado, including the LGBTQ plus youth population. Thank you.
Great question, Marjorie. Thank you so much. And thank you so much, Gordon. I think we need to keep moving forward here. So we've got on the deck next, Monique.
Hi, my name is Monique. I am the CFO here at BHA. And I'm gonna have Kasha kind of talk us through the slide deck because she is living and breathing this application and she's been living and breathing it over the past few months. The one thing I did want to just to make sure and point out is that this is all, pretty high level as far as our application content goes. However, after it is said and done and completed and reviewed and all of that, we are going to be pushing it out to members so that y'all can just kind of read through all the narratives and everything that we're putting in the application. And with that, I am going to pass it on over to Kasha, and then both of us can answer questions as they come up.
Thanks, Monique. Hey, everybody. Good to see you all again. So we're going to dive into the planned expenditures for the funds that we are currently applying for. So as a refresher, we receive annual allocations for each block grant program. So we get an award for substance use prevention, treatment, and recovery services, and we receive a separate allocation for mental health block grant. Both of those programs have their unique priority populations and regulations that we have to comply with. We're anticipating $16.9 million for mental health block grant in federal fiscal year 26-27, and we're anticipating 36 million from the SUPTERS block grant program for that same time frame. Those allocations are not finalized, and they will likely change depending on federal budget availability. States don't ever know how much money we're actually going to receive at the time of applying. We find out later down the road. And so SAMHSA encourages us to use the amounts that we received in the previous year as kind of a placeholder for what we can anticipate next year. So just wanted to mention that those numbers could be in flux. When we apply for the funds this year, we will not contract with them until state fiscal year 27. So we're working about a year in advance to plan out how we're going to apply these funds. These next few slides, we're going to look at mental health block grant, and then we're going to take a separate look at substance block grant. And we have a couple of visuals to help illustrate different breakdowns that I thought y'all might find interesting. This first slide here talks about how much money from the mental health block grant we're planning to spend on direct services versus non-direct services. Non-direct services, I think of those as kind of infrastructure costs and other system improvements. And we have to report each year on how much we spend on direct services versus non-direct. So that's what this table is telling us here. You can see the biggest bucket, 71% of the mental health block grant will go towards direct services. Things that we'll pay for include crisis resolution teams, first episode of psychosis programming, which is one of the required set-asides for mental health block grant, crisis services, which is another required set-aside for the block grant, safety net services, tenancy support, and transitions from hospitalization. And then if we're looking at the non-direct services that we have identified for this award, we're planning to put funds towards training for peers, data management or data system development, our learning management system, and the annual consumer satisfaction survey that we use to inform our block grant reporting. We have 5% of funds allocated towards administrative costs, and that includes staff salaries and travel. Next slide, please. So this is talking about that same pot of money, but looking at it a little bit differently to show you how much money we are putting towards each of the set-asides that are required of mental health block grant. So we have a 5% cap on administrative costs. So we're required to maintain compliance with that regulation. And you can see that we're coming in just under 5%. We're required to allocate 10% of each a mental health block grant award towards first episode of psychosis programming. And you can see that we're planning to allocate 12.9% to FEP. And then crisis is a 5% set aside that we're required to hit. But you can see at 21.5%, we are well exceeding that set aside requirement. And then the 60.7%, those are funds that are going towards either direct service provision or non-direct services, but they're not impacted by the set aside. So this slide is really just kind of illustrating how much money from the mental health block grant award we're putting towards the set asides. Next slide, thanks. Okay, so this slide, since we had our transition to the BOSOs, and since BOSOs receive the biggest chunk of funds out of the mental health block grant, we thought it would be helpful to provide a regional breakdown of that. And we have a BOSO region map at the very end of this slide deck, if that's helpful to reference as we talk through how much each region's getting. But you can see that BOSO Region 1, which, let me pull up my map. Region 1 is Rocky Mountain Health Plans, and that is largely the western and southwestern part of the state. They'll be receiving 24.5% of this award. The BOSO in Region 2, which is Signal and kind of eastern Colorado and northeastern Colorado, they'll be receiving 18.8%. BOSO Region 3, which is El Paso, Teller, Jeffco, Boulder, Park, they'll be receiving 11.9%. And BOSO Region 4, which is the metro area, will be receiving 44.8%. Next slide, please. Oh, wait, sorry, my bad. So when BOSOs receive these funds, they'll primarily be used for crisis resolution teams, first episode of psychosis, services along the crisis continuum, and safety net services. Next slide, please. Okay, now we're switching gears to the substance block grant, and we're going to run through similar looking slides, same sort of approach. So this is the comparison for direct services versus non-direct services for SUPTers. Our largest bucket is direct services at 78.6%. And the services that will be provided with the award include crisis, substance use disorder treatment, recovery support services, involuntary commitment incentives, primary prevention, SBIRT, gender responsive services, and substance use disorder treatment and services for maternal and child health services. Some of the non-direct services we're planning to fund out of this award includes a needs assessment, data migration and data system improvements, peer credentialing, and care coordination training. And administrative, again, includes staff salaries and travel costs. Next slide. So this is the slide similar to the mental health block grant slide where we showed you how we're satisfying our set aside requirements and the funding restrictions. So you can see we're right at the 5% administrative cap for our SUPTers award. 20% has been allocated, will be allocated to CDPHE prevention for primary prevention. And then the rest of the funds are not restricted to any set aside and will be used for direct and non-direct services. Next slide. Here is the BOSO overview of the SUPTers awards. So 20.6% will go to BOSO Region 1, which is the western part of the state. BOSO Region 2 will receive 14.8%, which is the eastern part of the state. BOSO Region 3 will receive 31%, and that is kind of the El Paso, Boulder, Jeffco area. And then the final Basso region will receive 29.7%, and that is the metro area. We do have a planned expenditure that that will support all regions. I am not entirely sure what project that is, but we do have some funds that will be split across there. BOSOs will be using those funds to primarily provide crisis support services, substance use disorder treatment, and recovery support services. Next slide. Oh, and then we're just at that BOSO regional map. And when we transitioned from the CMHCs and ASOs and MSOs to BOSOs, those funds were supporting the previous intermediary system, and now we have transitioned those over to the BOSO. And as Monique mentioned when she was kicking off this section of the presentation, we'll be providing y'all with a full copy of the application as soon as we have it finished and ready to go. But we wanted to make sure to get in front of y'all, share our goals and our planned expenditures, instead of just giving you the 200-page application and saying, good luck reviewing this. So I'm glad to get in front of y'all and talk through some of this information, so you can have this in mind when you look at the application. And I think that's it. Let's see, what questions here? Tasha asked, how is the set aside tracked for accountability? We have Brianna Obb on the call. She's on the fiscal team, and she is our finance data manager. She monitors how many expenditures are hitting each set aside requirement. We have charges coded in a specific way that helps us identify what charge that will count towards. So we have codes set up for FEP, crisis, primary prevention, so we can identify those as they come through, and Brianna's tracking those throughout the year, and it is quite the job, let me tell you. And then let's see, how are the BOSOs? I'm not sure what that question means. Would the person who put the question about BOSO support in chat, would you want to come off mute? And
Jenny.
Yes, that was me, Jenny Gencheva. So the initial impression is that BOSOs are very inaccessible. And so we're hoping that this is going to improve, because obviously they're in transitioning with all the issues this year. But how that process is going to be managed? Who is going to be assisting the BOSOs to develop a more hands-on relationship with the providers?
Is anybody from BHA on the call?
Yeah, I can field that, Kasha. Hi, I'm Melissa. I'm the BOSO Division Director. Great question. I think with year one, the goal is really to encourage BOSOs through regional councils that are being currently in process of identifying members to help guide those relationships with direct providers and connections in their own regions and communities, so that there is a more regional focus instead of just, we're your BOSO, here's the money, good luck. There are many expectations in the contracts that the BOSOs have around their own outreach and engagement plans, long-term strategy planning, especially for priority populations. And the regional councils are just one way in how this is being accomplished, but this being year one, that we're still very much in the infancy phases of that. I think as far as accessibility goes, because of funding limitations coming into this fiscal year, happening at a federal and state level, One thing that the BHA was able to do was at least maintain existing services that were already happening within the state for crisis mental health and substance use services. So unfortunately, yes, there are providers that were not able to access BASO funding because of the limits that existed there. And so as we, though, develop the BASOs, I think over data collection throughout year one, we're really going to be able to see, though, where are there community gaps for priority populations and other treatment services that we can build closer connections with, and potentially look at, then the BASOs deciding where that money needs to go through their own award process. So we're still very much at the implementation phase. I welcome any, though, additional feedback. As division director, I want to really be aware of any concerns or issues around accessibility with the BASOs and that provider network. So I see Judith put my email in the chat. If there's any other additional details that would be helpful for me to know about so I can work with our BASO partners and my team, I would really greatly appreciate that.
Thanks, Alyssa.
Thank you very much, Alyssa.
I see a question from Hope. Hope says the BASOs are receiving a significant portion of the mental health block grant and substance block grant awards. Can you clarify how the remaining mental health block grant and substance block grant funds are being allocated? Yeah, I touched on that a little bit in, let's see, slide 33. So for mental health block grant, the BASO's chunk is in that direct services line. And outside of the BASO's, additional efforts that are included in that 71% include an interagency agreement with the Department of Local Affairs for tenancy support. And we have funds going towards Rocky Mountain Human Services for transitions from hospitalization. And the final non-BASO direct service that's being that we're planning to contract for is first episode of psychosis training and programming support. And then for the substance block grant, if we skip to slide 36, that 78.6% of direct, the BASO's costs are included in that 78.6%, but outside of the BASO's, we are funding peer credentialing, gender responsive services, and maternal and child health efforts. So those are the only direct services that fall out of the block grants that are going towards treatment. I hope that's helpful.
Yeah, that's helpful. Just to kind of get a sense I didn't realize which was the BASOs in the presentation. And then I guess for what you've just shared, DOLA, Rocky Mountain Human Services, in these different kind of entities, will there be a breakdown that we'll be able to see of those specifically like you've done here for the BASOs?
I am, so like we're budgeting for this like a year out. And like since the block grants are provided to states to like with some flexibility to fill gaps and use the funds to meet individual state needs, our plans often change once we know what state budget availability looks like. And as the federal landscape kind of continues to change, these plans could also change. So as we're, I think that I came maybe about 6 months ago and presented on like the expenditures that we had. Our plans are kind of constantly in flux, at least at this point. So I'm happy to follow back up once we've kind of solidified amounts that will go into contract for FY27. But right now we don't have a very concrete, detailed breakdown to share.
Thank you for that. Appreciate it.
Of course.
This is Megan. Kasha, thank you. I think we would love that follow-up. It just helps us to better understand the landscape. So thank you so much for that offer.
Yeah, for sure. Oh, geez. I just saw Judith's message about last question at 10:40. Sorry, Judith. I'll pass the baton back to y'all.
Marjorie.
I just wondered if we are tracking at all the impact of budget cuts at the state, local levels, federal levels, and the just kind of somewhere keeping track of those things that we're losing so that we really can be clear on. Sometimes we focus on what we're continuing to do, but I think it's equally important for us to be tracking those programs, those services and supports that are going away because of lack of funding. Is the state doing anything to kind of keep that list so that we are aware of where things are going, what we need to be fighting for, or what harm is done because we are losing certain supports and services that are so valuable?
Yeah, so the governor's office and the state is they're each state agency is currently kind of assessing impacts and planning a legislative session at the end of the month to attempt to address some of the anticipated impacts. I see Kayla with her hand up, so I'll let Kayla chime in here.
Yeah, I can say that with the instability we faced at the federal level, what we have focused on doing is building tools that can kind of adapt to that, give us a picture of our funding and where it's sitting now, what, what's coming from substance use block grant, mental health block grant, or our state funds, how much of those state funds can only be used for one purpose versus what's flexible. And so since about February, January, we've been working to build out tools that when an impact becomes real, and we know, right now there are unknowns about how much of an impact something might be, but as information actually comes to fruition, like knowing what kind of cut Medicaid got in this legislation, we are able to sort of plug that into these tools that help us analyze what hole does that create, what funding sources could come in to fill that gap, and then comparing that to BHA's priorities of access to care, care coordination, crisis services. So keeping sort of the very core pieces of work as our guiding star, we can do analysis now to kind of adapt when real information becomes known.
Thank you. I just wondered if there's a way for local communities. I think there's certainly a lot of other programs happening in the state where we could contribute to some of that list of where, for the lack of a better word, harm is being done because of cuts. So I think it's important that we have that communication, that where you're collecting it, but also where we in our different worlds are hearing things, that we can, maybe planning council can be a place that we can share those what's happening at the ground level.
Megan.
Okay.
Thanks. Just to build off what Margie said, I wonder if, if the data you're collecting is also being captured from other state departments as they see funding loss, right? As we know that oftentimes what we do now is say, oh, well, we might not have the funding, but we know who does, right? And we know that's changing too. So I wonder, Kayla, as you're doing this data collection, if you're just, kind of collecting those bits of data as well, and perhaps we have a platform that we can share into where maybe it's not your like master data platform, but a data platform that, to Margie's point, we can say, oh, look, we noticed a service went away in this community. So then you're also capturing that, the grassroots and grass tops, and be thinking collectively on how, as funding shifts, we're shifting to meet the needs of the community where the funding still exists, instead of assuming there's funding in spaces where maybe it's gone away. We might not know that, but maybe you guys do.
I think I passed to Monique too, as she's been our CFO, and we've been partnering on.
Hi. So I love that. I love the idea of sort of using this forum to collect not only data, but like impact stories. And I will tell you that I am in like daily contact at this point with the governor's office, who is really, really centralizing all of these stories, all of this data, all of this collection, where we're working closely with HPAC. And look, we know that like the effects of HR1 are going to have a significant impact to Coloradans. We're talking about 200,000 plus folks being kicked off Medicaid, another handful of folks losing private insurance or being priced out of the marketplace. And so that is such high priority right now. It's just about all I'm thinking about at this moment in time. So we've got, not only the fear and all of this stuff circling around about what might happen to, federal grants, the block grants and the discretionary grants. We're feeling good about block grants. These two grants in particular, we're keeping our ear to the ground as far as it comes to discretionary grants, but really that work is being centralized. It's flowing up through all of the agencies, up through the governor's office. So just yesterday or the night before, Governor Polis put out an executive order talking about what we think the impact statewide is going to be, and calling for a special legislative session like Pasha alluded to. It's going to start on August 21st, and that's pretty significant. They're calling an extraordinary session to try and find some of the holes here. I would say we welcome all data, but we also truly, truly welcome all impact statements, stories of harms that you're seeing, a particular story, because we use those in all of our appeals, in all of our budget requests and all of that, because it's just really effective to use those stories. Often go a lot further than data. If you've got a family or a particular person or situation, we welcome all of those stories to include in sort of the overall picture. And I know it's not like a great answer. I just think we're trying to work through it as a state, and I know I'm closing in on time. Together, there's a lot of unanswered questions, but it's day by day by day. Things are changing, and it's definitely being addressed.
And Monique, where do you recommend, or where is the place, the platform, space, website that we share our impact stories, so we know where to properly do that?
That is an excellent question. Does anyone have any great ideas to collect this? I mean, I'm happy to have you, email them directly to me. However, I don't know if there's a better forum. Maybe we can have Judith maybe help us with some of that, because it's all really, really, really appreciated.
Yeah, we could organize something for the council to put together stories, and then we can submit that to you.
Thank you.
Thank you. Judith, do you want to take, I know there was a statement, and we've got 3 minutes till our public comment. I just was going to turn it over to you to.
Okay. I think we're going to pivot. Marina, could you please bring up the agenda again? This has been a great meeting. Thank you all so much for your time and staying engaged and asking great questions. I just wanted to go through, kind of what our plan B is going to be with the remainder of our agenda items. So what we mostly have left is council business, so our membership update. I'll be able to send all of that via email. I will say that, after our last meeting with the membership subcommittee, we realized that we may have enough really to fill the necessary seats we need to fill for next year. And so I just have to kind of go through all the applications that have come in, and also create just a separate document for you all who are returning to fill that document instead of filling the big application. You really don't need to fill the big application if you're returning. And so I will send all of that via email to you all with some action items in that. And so keep an eye out for an email today or tomorrow. Otherwise, hope I don't have anything else, just what's going on, just doing another plug for our community conversations. Those have been great. They're still ongoing. Would love to see you at any of those upcoming ones that you may be near you, and also really looking for this council to spread the word about these meetings. But otherwise, Hope, I think we'll be okay to open up for public comment. There was a question earlier on.
The one thing that we need to address as well is we just received and heard from the BHA on recommendations and goals. And so now as a council, we have an opportunity to add and more align with what we've heard our recommendations. So we've got an opportunity to do that. And so I know that Judith is going to send out our current spreadsheet to the council members so that you can, based on what we've learned here, based on what we know now as the BHA recommendations, you can continue to add on our recommendations to align, to highlight. I know that we also have questions that probably are going to come from the presentations. So Judith, where do you recommend, I know we had talked about having, is that within this recommendation, or where can the council add any additional questions that come up from our amazing presenters today?
So the great thing is that spreadsheet has multiple tabs. And so we have an additional tab just for today's meeting. And so we're going to have a section in there to submit more questions for responses from the presenters. And so I'll submit those questions to the presenters and send it back to council.
Wonderful. Okay. And so because we are on a deadline to get our recommendations completed, we are asking that the council that you have take time to work, to look through the recommendations, add what you have, add your shares. We want to hear your voice. And the deadline to do that is next Wednesday, because Thursday we have our subcommittee meeting on our recommendation committee. So have those please review, add by Wednesday next week in preparation for our subcommittee meeting on Thursday. So Judith will be sharing that via email to our council members. Whew. Okay, we got to turn it over, I know, to public comment. Did I miss anything, Judith or Megan, in what we wanted to capture before we did this? Okay. Whew. Turning it over for public comment.
We had initially received a question during the presentation from Kate. And so if Kate is still on, if she could please come off mute and ask, or we can share it also. I can find it and read it as well. I'm just scrolling back up to that question. There you go, I found it. So Kate had asked, is there a written plan for these priorities and goals and objectives, and where can I find it? Kasha, I think this is a good question for you if you're still on.
I'm so sorry. Could you repeat that one more time?
Where is a written plan for the priorities that you presented and the goals and objectives, and where can the members of public find these?
Yeah, so we're preparing that information to go into the application, and once we have it, you'll be shared. We'll share that with you, and it will have the priority areas along with the goals, the strategies, and the data metrics.
And Kasha, I believe there will be a public comment period as well before it's submitted.
Yeah, so we have a block grant webpage on the BHA website that provides the public with the ability to submit comments at any time throughout the year. And also we are working with our comms team to create a blog post to kind of advertise this this application submission. We can't post it publicly until we're done. So we're up against the deadline here and getting everything as ready as we can, but there's just a couple of dependencies. We have to do an internal review of all the information, and once we have the blessing to submit the application, we will post publicly.
And this is Megan, you guys. Look, if you are like, I want to comment, the document's confusing, just extending the invitation again to our members, please call me, email me. I'm happy to listen and type for you or help you to make sure that your recommendations make it into the document. So don't let all the other things keep you from adding what you need to add in this conversation. I'm happy to listen and help.
Thank you, Megan. That is so supportive and wonderful. And I just want to, we're at time, so I want to thank everyone that is here today. Thank you to everyone that presented, our state agencies that are working so hard. Thank you for making this time for us as we navigate these real complex times. So thank you to everyone for being here. Our August meeting is adjourned. Take good care. You know where to reach out, and Judith will follow up with some additional components. So thank you, everybody. Take good care of yourselves, please.